Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Back again for part 2 with Dr. McIntosh. So exciting. Hopefully you all listened to part 1, which was all about allergies, and you already know who Dr. McIntosh is, an ENT specialist in Australia with specific expertise in airway obstruction, facial and dental development. He knows about airway problems. He works alongside all of our colleagues, dentists, orthodontists, sleep doctors. So he is the guy to help answer all of these airway type questions. So last time we talked a lot about allergies, and we learned that allergies are significantly linked to asthma. And there's a similar response going on. So I want to talk about that today. And I also want to talk about tonsils and adenoids if we have time. If we don't, then we'll do a part 3, 4, 5, 6, up to 10. I don't know. But I think we can cover both of those in this episode. Can you talk about what exactly is asthma? That's one of my questions. Is it ever misdiagnosed or overdiagnosed and really something else like pulmonary reflux from sleep disordered breathing and that irritation or inflammation? And then how is it linked to allergies? Can you go over all that?
For sure. So look, let's draw some lines in the sand. I'm not a lung doctor. I'm not a lung specialist. I live on the top half of the body, or top part of the body. So, but asthma is an airway lung disease, which has an element of what's called bronchoconstriction. So the breathing channels constrict. And the thing that defines asthma is that constriction is reversible. So with medication, we can reverse that constriction. So this is as opposed to irreversible constriction for other types of diseases. This is reversible airway obstruction within the lungs themselves. And there's many things that can trigger it. Allergies gets a mention, exercise for some people, infection for others, temperature of the air being cold, different people, different strokes. So that's the gist of asthma in terms of, as far as the weeds that we probably need to walk into before I start feeling like I'm getting out of my territory a bit too far. And the important thing that ties...
Just one question, just to interrupt. I know you said about breathing channels constrict. Is it like excessive mucus production in the lungs, or is that not?
Well, they get that as well. Yeah, and they get what's called mucus plugging. So, so that's there. But the big one is the constriction. That's the big picture. When they constrict, they don't drain as well. You get some blockages. The mucus doesn't clear. You get what's called mucus plugging, which just exacerbates things. So, yeah, so that's obviously not ideal.
Okay.
Yeah. And then with the allergy side of things, there's a big overlap. It's close to half the people with allergies and asthma, they're coexisting. You got one, half the time you've got the other. So, and we know that when it comes to the control of asthma disease, that it's far more effective if they've got allergies, that you're actually treating those allergies as well. So if you have what we call treatment-resistant asthma, that can be in the context of having allergic disease that's causing it all. Now, the symptoms of asthma is, a breathing problem, wheeze, a cough, are all sort of common things that can tie in with this. And you mentioned something called reflux. So reflux describes a condition where stomach contents are coming up, and we have two types of reflux. We have the lower reflux, which is what we call gastroesophageal reflux, which is reflux that's coming up from the stomach, but it's just getting into the esophagus. And that reflux tends to be a problem when there's a lot of it. So that's a high volume, low elevation of reflux. And then we have a different type of reflux, which is, called different things. It gets called ENT reflux, gets called silent reflux. It gets called laryngopharyngeal reflux. And that last one sort of, again, relates to the anatomy as to what gets irritated first. When you come up from the esophagus, the next thing you get into is the throat. And right sitting there is the voice box. That's the laryngo part. and throat is the pharynx. So that's the laryngopharyngeal reflux. And that can cause asthma-like symptoms. You can get a reactive wheeze from that, and you can get a cough. The other thing that you can get is that you can get nasal congestion and a nasal drip. And that's for different reasons. One is a mediation through the vagus nerve. Another one is through chemoreceptors. And another one is if the reflux keeps going, it can actually in people get into the nasal passages and cause a local irritation. So they can present with asthma and allergy-like symptoms, a cough, wheezy, runny nose type scenario. But it's actually not allergies and it's not asthma at all. And the clue there is that when you do the lung function testing, you don't see the medication changing the lung function. So that's a clue that it's actually not asthma.
Okay. Can I ask a question again? I feel like I'm in class and I want to raise my hand. Teacher, can I ask? Okay, so my question is, I've always wondered this. My son, when he was 2 years, 11 months, his tonsils and adenoids removed. He always had a hoarse voice, maybe from yelling, from vocal misuse, from being hyperactive, but he also had reflux. And when they did the tonsil and adenoidectomy, they viewed his vocal cords, and he did have a nodule on the vocal cords. And I asked the ENT if that could be due to reflux. Well, that ENT said no, because the acid doesn't go to that part. What do you think?
The ENT is mostly right. The reflux affects the back part of the larynx. So what we see is on the back part of the larynx is the soft tissue swelling. It's called the ADENOIDS. They will sort of get red and swollen. Very, very rarely will the vocal cords get swollen. It's something called Reinke's edema. It's usually more common in people that are smokers. But that's where the whole surface of the vocal cord gets swollen and irritated. The nodules are pinpoint irritation. Typically happens at the junction of the front 1/3, back 2/3 of the vocal cords, and that's contact pressure. That's vocal, misuse. Mouth breathing will exacerbate that because the dryness exposes things to more changes if there's irritation. And look, the reflux could, potentially exacerbate that irritation too. But to throw reflux into the mix for a unilateral vocal cord nodule, if it's in that typical position anatomically, I'd be on that same side of the fence as the ENT. Look, it could have contributed, but you're missing the big picture.
Yeah, and it was unilateral, and it was on the lower, like 2/3, like the lower third on the bottom of one side. And
in which case the reflux. In which case the reflux could have been in which case that reflux could have been a contributing factor.
That's what I was thinking. But I was curious about that because again, our body, our system is united. It's linked, and our kids who aren't breathing well, aren't sleeping well, they're hyperactive, they're screaming and running around like crazy. So it could have been him yelling like crazy, misusing his voice. Okay, so that's really interesting to know. So talking more about asthma, okay, can you talk about, you just talked about the link of reflux and the different types of reflux and asthma. Can you talk more about what's going on with asthma and how to treat?
Yeah, well, the other link is sinus disease, especially in what we call adult onset asthma. So most people that get asthma, they get it in childhood. It has varying, course of disease. But there's a group of people that get adult onset asthma, and, that can be due to, environmental exposures. They're working in certain occupations where the air is not clean. There's the irritation and so forth that comes from that. But there's also a group of people where it actually starts off as a sinus problem. And again, it sort of flows from that thing that we talked about, that united airways disease, that whole nose, sinus, lungs are all sort of the same system, just different parts of the body, but there's an interplay. So, and again, also the same thing in treatment-resistant disease is to whether they've got some form of chronic sinus disease going on, because again, the body's dealing with the chronic sinus disease element, which is a disease of the same effective skin lining as the lungs, and we can get this overflow systemic effect. The other thing which we're going to sort of bounce into when we talk about asthma is going to be sleep disordered breathing, because we know that sleep disordered breathing and asthma also aggregate. Now, part of that is because of the nasal allergy story. That's sort of, part of that cluster effect. But independent of that, especially in children, we see this overlap between asthma and sleep disordered breathing. And the link is thought to relate to the fact that sleep disordered breathing as an entity generates a body inflammatory response. And if you've got another disease in your system, such as asthma, which is, can be an inflammatory driven disease, then that makes that worse. And we do have some evidence and findings that shows that when we do tonsil adenoid surgery to relieve sleep disordered breathing, that asthma severity actually can decrease markedly as well, which sort of again highlights the link between them being the case. So again, it's like you keep saying, you got to look at that body as a whole, that holistic approach to everything's connected here.
Mm-hmm. What about like breathing retraining programs where people are learning to hypoventilate in order to decrease the body's sensitivity to carbon dioxide, and that could possibly help with people who have asthma? Do you have experience or
Yep.
understanding with that? What are your thoughts?
Yeah. So unfortunately, that's a corruption of physiology. The breathing control in people is the brain takes place first and foremost. Now, there's things that you can do to take over control, initially and so forth, but eventually the brain's going to resort back to I'm in charge. What you're referring to in that context is really just highlighting again the importance of differentiating between asthma and asthma-like symptoms. Because, and I had asthma as a kid, so I know exactly where I lived, growing up with this thing, it's very scary. And when you get upset and you start to, get a bit worked up, that can lead to you falling into an asthma-like state. And it's not actually asthma. It's actually a bit of a panic anxiety attack. And people have looked at this. There's rating scales for these things. It's called the Ninjman scale, where they look at what is the anxiety state of people with asthma versus those without. And those with asthma do have an anxiety tendency, and for good reason, because they've had breathing problems that are damn scary. So that it all kind of makes sense. And what happens in those scenarios is that when people go into those panic states, they will reach for their asthma medication straight away. They just go, oh my God, I'm going to die. I'm going to reach for a medication. When in actual fact, it wasn't an asthma attack at all. Okay. It was a panic attack. All the startings or variations on that theme. So this breathing retraining does reduce people's need for medication, but that is because it is addressing their anxiety tendency, not their asthma. And that is the big difference between making an observation and making a conclusion. Because, historically, every morning the sun would go around the earth. You would see it come up and go around the earth. Now, we know that the earth goes around the sun now. And the only reason we know that is because some clever people told us. Like, I can't prove it to you. I take their word for it. But, if you're making some simple observation, did a breathing training thing. During that moment in time, we measured their carbon dioxide and it changed. So we've changed their carbon dioxide sensitivity, and that made their asthma, less of an issue. What you've actually done, like any, breathing retraining thing that you want to nominate, has a knock-on effect in terms of anxiety control. And we see that in yoga. Okay, you can go and do yoga, and they're getting amazing results out of some research that's coming out, where they're actually talking about rolling it out in the schools in the US. They're starting out in Puerto Rico, though, just because it's logistically easier, where some basic breathing and yoga postures are going to be part of the PE curriculum, the physical ed curriculum, because that was translating into children being more grounded, being happier, and so forth. And that came from a childhood psychiatrist who brought it into his office for his own stuff, because his office, they were seeing a lot of childhood trauma, as a clinician, and for his staff, that was traumatic for them. And they were actually, finding that they were getting personal benefits out of a bit of breathing and yoga training for their own mental health and well-being, less prone to anxiety and so forth. And that's exactly what I think is going on with the breathing retraining in the asthma cohort, is that, people have ascribed an outcome based on measuring certain things, when the actual fact is probably the fact that you're just making this person calmer, and that they have some breathing strategies that they can bring into. So when they start to have what they think is an asthma attack, instead of reaching for the medication, they can trial some breathing retraining first. And in that scenario, de-escalate before the so-called attack even plays out in the first place.
Because the anxiety can trigger the asthma attack, right?
The asthma-like attack, yeah.
Okay.
There's a big difference, because an anxiety attack is not asthma. It's a breathing panic thing, and you can get into an asthma-like state where you can start getting wheezy and noisy and so forth.
But it's not a real asthma attack.
But it's not the asthma attack, because if you sort of, I can remember, I'd get these attacks, and I'd go to, we had a school nurse back then. I don't know if schools even have nurses anymore, but it was a school nurse, and she was switched on because we had the medication there, but it was just like, no, I think you just need to slow your breathing down, just take a few breaths, and it would calm down. No medication. So, you can't talk yourself out of an asthma attack.
Can you talk yourself into an asthma attack? Like, could a panic attack,
or asthma-like attack,
but it's not a real asthma
well, it
attack?
manifests. It's not the full asthma attack that we're talking about in terms of the bronchoconstriction and so forth that comes about.
Okay, that's interesting. I didn't know that. So the correlation between asthma and sleep disordered breathing is there's that inflammatory pathway.
It's the inflammatory thing is the pathway that seems to be the link. Absolutely.
And then I feel like a lot of people get diagnosed with exercise-induced asthma. And it's like, is that really, like, get your little inhaler for when you go for your run? But is that really asthma, or?
Well, it was for me. Yeah, it made a huge difference. So we used to have every year we'd do this run where we'd run for a mile. And the first few years I did it without, and then the last few years I did it with the spray beforehand. And I don't know how much of it's placebo versus real, but I did much better having that on board beforehand than I did without. And it also then sort of, ties in with the breathing part too, because if you're a mouth breather, for example, and you're breathing in that sort of air, it hasn't been warmed, it hasn't been filtered, that irritates the lungs. And that irritation can be part of the story of asthma as well. But again, you just got to put it into context of making sure we don't, step too far away from the middle there in terms of what it is.
Okay.
But yeah, what can
So the mouth breathing can irritate the lungs?
Yeah, absolutely.
Okay. And because the air is not as filtered, moistened, warmed, things like that?
Correct. Warmed.
Okay.
That's a problem.
This is perfect segue too, because if we want to talk about tonsils and adenoids, well, I want to talk. I don't know if you want to, but I want to talk about tonsils and adenoids, because that's,
I might know something about it.
You might know a little bit about them, but a lot of people say, I know you're not, you don't think along this lines, but a lot of people do say that mouth breathing can cause irritation of the tonsils. And I know that's not one of the main causes. So I want to hear from you, like, what would you say the main causes are for enlarged tonsils and adenoids, and how does mouth breathing play a role if it does?
Okay, so we've got to look at the outcome versus the process. Okay, so when they turn up as mouth breathers with big tonsils, all we can say is that they're mouth breathers with big tonsils. That's all you can say. You cannot make any inference as to what's caused what. All you can do is say, this is what I see. Okay, so let's rewind for a moment. So, and again, I grew up with this. So when I was going through my training and so forth, there was this thing called biofilms that hit our radar early 2000s. And we thought biofilms was the explanation to all the ENT infective diseases you could mention, sinus, tonsillitis, middle ear disease, and the works, because with the technology, they'd found these vegetative growths of bacteria, which we now call biofilms, living there. So people that have had dental plaque is probably the easiest one. That's a biofilm, okay? That's a basically bacteria that form a sort of a slimy thing that then dries out a bit, and they live in this sort of protective casing until some of them wiggle free. And it's when they break free that they actually cause active disease. When they're in that biofilm state, they're not causing active disease. They're pretty metabolically pretty dormant, which is also why antibiotics don't work for biofilms, is because the bacteria aren't turning over enough for the antibiotic to actually impact on their metabolism. That's by the by. So we thought big tonsils and adenoids was reaction to biofilms. And we went down that rabbit hole really hard and really deep and didn't come up with much of any use. So we were like, oh, okay, that was a bit of a waste of time. What we tripped over in 2016 was the paper that came out that was looking at viruses. And we looked at the viral load in big versus small tonsils and adenoids. And the viral loads were much, much higher in those big tonsils and adenoids. And the speculation then was, well, maybe it's the ongoing reaction to those resident viral particles that's leading to the tissue getting bigger. And then they looked at the mechanisms and cellular reactions that all actually added up. So that's the best thing that we've got going for us, is that it's the way that your immune system reacts to viruses. Now, we all get exposed to viruses every day. Right now, you and I are getting hit by viruses. We don't even know about it. That's how good our immune system is. And part of the job, as people will tell you, oh, it's a filtration. Yeah, only to the point when it starts to get blocked and starts to get dysfunctional. And if those viruses take up residence, then it starts to become a problem. And so the body fights it some more. And the way it fights it some more is by making the tissue get bigger. You know, it's like going to the gym. You know, you go to the gym, you change your muscle composition. Well, it's the same thing here. It changes your lymphoid composition and it gets bigger and it gets bigger and it gets bigger. Now, we do now know that bacteria do play part of the role. Certain ones do, most don't. And also that reflux and cigarette smoke exposure plays a role. So they're contributing factors. But the big one seems to be viruses, okay? And then you go, oh, we get rid of viruses by breathing through your nose. Well, I hate to break it to you, but we don't. The reason that we can prove that is we completely jump ship for a moment, and let's talk about the ultimate bypass of the upper airway. People that have had surgery for cancers and have what's called a tracheostomy. Those people with a tracheostomy, they're not getting, you know, greater numbers of lung infections from breathing through their trachea and bypassing that whole filtration process. So, you know, we've got to be careful about, you know, what we make assumptions and assertions about versus what actually translates into reality. So that's not to underplay the importance of, you know, these filtration effects, but we can't ascribe, you know, a great amount of significance to them either, relative to what our immune system actually does, because that's really is the big picture.
Okay.
So we seem to get it from the big tonsils and the adenoids. Now, when I was presented with this whole mouth breathing causes big tonsils things, I was like, okay, well, let's just rewind on that for a sec. I focus on airway a lot. I'm going to go look at all of my mouth breathing people, you know, kids that are fixed. And of those, how many of those was I also removing their tonsils versus doing adenoids or turbinates? Most of the mouth breathers that I see do not have big tonsils. Mm-hmm. So that as a starting point undermines the theory that, you know, mouth breathing is causing the big tonsils, because most of the mouth breathers I see is due to adenoid and turbinate problems, and their tonsils are perfectly fine. So if mouth breathing causes tonsil problems, I should be seeing a lot more tonsil problems than I'm seeing in those mouth breathers, and I'm not. So that was the first thing. The second thing is I span it the other way. And I said, well, those that have got big tonsils, how many of them are mouth breathers versus not? And a lot of them were mouth breathers. So it's the tonsils can cause mouth breathing. People always think about mouth breathing as being a nasal level problem, But to breathe through, be a nasal breather, you've got to get through the nasal passages, through the back part of the nose, back past the palate, past the tonsils, and beyond. And the tonsils are a 3-dimensional structure. We always see them in 2 dimensions, being side to side, but they go front to back as well. And we don't really, conceptualize that all the time. But those tonsils are big side to side. They're also big back to front. And that restricts the ability for airflow from a nasal point of view. So they resort to mouth breathing. So large tonsils is a cause of mouth breathing, even when the nose and so forth are perfectly fine. They can still end up being mouth breathers.
And
so
also,
I don't.
Can I say one thing about like function and myofunctional perspective? Also, enlarged tonsils can physically occupy tongue space at the back of the throat and can cause that tongue to want to rest low and forward. When that tongue's resting low and forward, it has enough weight to drop the mandible to cause the lips to open as well. So from like a physical functional perspective, also that can cause open mouth breathing from tongue posture as well.
Okay. Yeah, exactly.
You named
So I think that's sort of the difference between making an observation and making a conclusion.
Yeah. And also you named 4 things that contribute to enlarged tonsils: viruses, bacteria, reflux, smoke. What about allergies?
Yeah, so that's interesting. So allergies as a whole, it seems not, but allergies specifically mold seems probably yes. So it may just be a subtype of allergies. Now that came out in a paper only in the past few months out of China, where they were looking at allergies and correlating it, and the only one they found was with mold exposure. So that might also then explain, the United Kingdom observations, where their houses are a lot older and tend to be damp and dank because of their just their climate. So they have a lot more mold exposure, which means that could be feeding their observations of tonsil and adenoid problems and mold, which we don't tend to see so much otherwise elsewhere. Because most allergies, where in my part of the world, are driven by dust mite and grasses and pollen. Mold is a contributing factor, but nowhere near what it seems to be in certain places. So I think we've got to just keep digging that one a bit to fully understand where we're at with that one.
Yeah. And I live near the beach where I live, very coastal. And I hate the word mold. I didn't want to talk about it because when you go down the mold rabbit hole, that is very stressful. Like suspecting in your home there might be mold, and getting rid of that. Well, I think that is very stressful.
Let's address that anxiety. Now, I can remember the anxiety that came about when we started to see these pictures of house dust mite on electron microscopy. So electron microscopy is a special, like super microscope. And you can look at these dust mites, and they look like absolutely ferocious creatures.
Yes.
And people started getting anxious about dust mites. It generated a dust mite phobia for a while, and then that all sort of died down. And now we just we're interesting animals. Like we're absolutely preoccupied with finding something to worry about. When we can't find something to worry about, we'll just invent something.
Yeah.
So with mold,
I do that.
Yeah.
I have that
so
problem.
let's just put things. Yeah, well, let's just put things into a healthy context. Mold is everywhere. Okay, there are more mold spores in the air than there is pollen. So you always sort of get the pollen count gets put out with your environmental sort of measurements and so forth, which makes sense because it's a trigger for people. But there's more mold. Okay, ubiquitously, the largest living thing on this planet is a fungus, and it's living in your country. Okay, and it takes up acres and acres and acres and so forth. And we've come to understand how mold and fungus are a really, really important part of our environment. So we've learned to live with them, and they've learned to live with us. And they're really not very interested in us until we're, to be honest, dead and buried, because that's when we're useful to them. In this state, generally speaking, we're not so much interest to them whatsoever, and our immune system keeps it all in check. Okay. So we've got mold going in and out of us all the time. Like if we were to do, take a a sample from anybody's nose, anybody's throat, we will find mold. What does that mean? Nothing. It's
Unless
normal.
if you're allergic
So
to mold,
mold
right?
being there is normal. That's when it becomes the problem. So
Yeah.
having it is not the problem. When it trips over to a problem such as an allergy, that's when the dynamics change. And that's when you got to go, all right, what can I do to mitigate mold exposure? All right. I know we were on allergies before and we're back to allergies again, but that's okay. So there are some certain things you can do to mitigate your mold exposure. Okay. One is inside the house is get rid of the pot plants. Okay. Because the mold is in the soil.
Yeah.
So if you've got plants in your bedroom, for example, that's probably not the best place to have it. Okay. The other thing is, and this is only if you've got the problem. You don't want to create problems that don't exist. But when, for example, your bed linen and your clothing, dry them inside instead of outside. Drying them outside is basically like putting a net up to catch the mold that flows through the air, and then you bring it in. So if you dry them inside, that will reduce that outside environmental exposure to some degree. And then you can get filters and so forth. But the thing with the filters is you've got to get the really good expensive ones, and you've got to keep changing the filters. The other one that I see commonly, at least here in Australia, that people trip over with is with their air conditioning units. You need to get those air conditioning units cleaned because the mold that builds up is horrendous. And the other place I've seen it is with people with CPAP, especially with the humidifiers. They have no understanding or awareness that there's filters within that machine. And I've seen photos of mold buildup in CPAP filters. So again, there's things that you can do. Having anxiety is not one of them.
Yeah, and that's a good point. Is if you have an allergy or sensitivity, I think that's what triggers people to start getting worried. And it's important to know, don't fear mold because it is a natural part of the environment, and there's tons of mold when we step outside. In terms of tonsils and adenoids, are tonsils and adenoids the same type of lymphatic tissue, or are they different composition? Because I'm curious why one might enlarge and not the other. Why someone might have enlarged adenoids and normal-sized tonsils, or vice versa.
Yep. So it's like fingers and thumb is my analogy. All right. When you look at your fingers and thumb, generically, they're pretty much the same thing. Okay. But that thumb is one thing that makes us very, very unique in terms of what our hands can do, because it's what's called opposable. What that means is it can turn on itself and touch the other fingers tip to tip. So it's the only one that can touch the fingertips on the same hand. You cannot turn any other finger to touch each other tip to tip. Your thumb is the only one that can do it. So that's what makes it the same but different. Okay. And it's like tonsils and adenoids. They're the same in the mainstay, in that they're lymphatic tissue, they're around the throat region, and they play an immune, defense, which is very rudimentary. Again, don't want to underplay it, but let's not overplay it either. Very rudimentary immune defense contribution to the situation, but they're not exactly the same. So they will often do similar things, but they don't have to.
Okay. So the tissue is different. So is that why, like my one son had enlarged tonsils and adenoids, both needed to be removed. My younger son, it was only his adenoids that were enlarged and not the tonsils. So why would that
Exactly.
happen?
It's not proven because they're not exactly the same.
It just
There's enough subtle differences. So whatever the trigger in child one was enough to trigger both tonsils and adenoids, whereas child trigger number 2 was enough only to trigger the adenoids.
So,
and child number 3, it could be just the tonsils.
Now here's not a quiz, guess. My younger son, whose only his adenoids were enlarged, tonsils were fine, and his adenoids were significantly enlarged. Was he a mouth breather or not? What's your guess?
He was more likely to be a mouth breather, but not necessarily.
So he was
more
a mouth
likely to be.
breather, but his tonsils weren't enlarged. So that goes along with that. Your observation with
Well,
patients that mouth
again,
breathing doesn't necessarily cause tonsils to enlarge, right? Yeah, because his
no,
weren't.
no. The easy, lazy conclusion is that their mouth breathing got big tonsils. It must have been caused by the mouth breathing.
But no.
But then you'll see the next mouth breather that has normal tonsils, and you'll completely ignore what you
Yeah.
just said
Yeah, because my
without even thinking that
my
you're
son,
you're
major mouth
contradicting
breather.
yourself.
Yeah, major mouth
Yeah,
breather, tonsils were fine.
yeah,
So that's
yeah,
there you go.
yep.
Goes along with that.
There you go.
Okay. My mentor who trained me in orofacial myofunctional therapy, when she trained me to do evaluations, she said, whenever you see one tonsil larger than the other, that's a big red flag. They need to go right to ENT. So I'm wondering, is that an over exaggeration or is that a concern for like a tumor or something? And how much larger should,
Yep.
yeah, like talk about that.
Yeah. Yeah, yeah. So the very simple thing in ENT is that unilateral disease is a red flag. Okay.
Okay.
So, for example, a child that's getting ear infections, middle ear infections, but only one side, that doesn't make sense. There's like
Okay.
there could be some underlying pathology. If you sort of got persistent one-sided nasal obstruction, okay, especially if there's bleeding that's come on and it's new onset, you haven't broken it, you haven't knocked it, it was fine 3 weeks ago, but now it's totally blocked on one side and it's bleeding. Unilateral, that's a red flag. The reason that was flagged to you is just to basically, you don't want to be the person that sees something and then dismissed it, and then a month later this person's got lymphoma that you walked past. Okay. So it's a little bit of risk mitigation, where you don't need to know if it's serious or not. You just need to know that you need to get someone that will know to have a look at it. And you just say to the parent, hey, look, I'm just noticing in here, this one tonsil looks bigger than the other. Now, that could just be positional, but when we see these things, we have to assume the worst, because the worst is something that we cannot miss. And in assuming the
Slightly
worst, I just want you to see the best.
Okay.
Yeah,
And that's a good
it's
way
got
to
to be
word it.
it's got to be overtly. It's got to be pretty obvious. You've got if we can just talk grading systems for a moment. You're talking like something like that's a grade 3 or 4 on one side and a grade 1 on the other.
Okay.
There's a significant disparity there. If you're going like a grade 2 that's kind of like sitting at 48%, and the other one's a grade 3 because it's at 52%, well, you're splitting hairs there. That's not really an asymmetry of major standing. It's one tonsil is coming across to the midline, the other one is still sitting on the side wall, and you sort of go, this is really out of alignment here.
Okay. That makes sense.
Yeah.
Quick kind of sidebar, and this might be a silly, dumb question, but when we're grading tonsils, why is sometimes it's 2+, 3+? Are you supposed to include the plus or not, or is that meaning it's leaning towards the next number?
It's basically very, very subjective in terms of what somebody will write down. So I don't bother with the plus. It's just like 1, 2, 3, 4.
Okay.
What's really more important is basically what's the airway like, and what is the symptomology? Because we can see kids with grade 4 tonsils, they got 0 symptoms, and we and you're just like, how is this even possible? And you're desperately trying to find a problem so you can make it look better. But some kids, remarkably, they've you took a picture and go, these are the worst tonsils ever, but the kid is perfectly fine. So you've got to take the clinical context into it. So usually, sort of rough numbers wise, grade 1 tonsils, look, less than 10% of those are going to be a contributor to airway obstruction. The tricky ones are the grade 2, because it's a 50-50. Half of them do, half of them don't, and trying to work out which is which can be tricky as well. Grade 3, then you're sort of getting up around the 70 to 80% mark, and grade 4, you're getting around to the 90 to the 97, maybe even 99% mark, where they're going to be causing a problem. So the real tricky ones, clinically, are the grade 2, which is that sort of 50% obstruction, which means it's half blocked, half unblocked, and trying to weigh those ones up. They're the tricky ones, and that's where you get guided by the symptoms. Because if the kid's got sleep apnea on that spectrum and is really struggling, then you just go, look, I think we just got to optimize everything. where, you know, if the kid's not that bad, and you sort of go, well, maybe we can get away with a lesser procedure, better recoveries, you know, better safety profile. You know, in every scenario when we leave the tonsils, like even your son that you explained, you know, there is a lifetime chance of around about 10 to 15% that those tonsils will turn on us and we'll need to address them. But, you know, as I say, look, you know, if that happens, well, at least we deal with it. What it means is 85 to 90% of the time, it's an operation that's not needed. So if it ain't broke, don't fix it.
That's interesting. And I'm wondering, like, well, obviously we as dentists, myofunctional therapists, we visualize the tonsils, well, you can from imaging and also looking in the throat, but they're also like encapsulated, right? Or what's that word? They're kind of in a
Well,
housed in
they sit in a capsule.
okay.
Yeah. So the tonsils basically sit in a cup.
Okay.
It's like an egg in an egg cup.
So we're not obviously visualizing the entire tonsil. So is it possible that they
Not at
might look
all.
normal size to us when we look in the throat, but when that patient lays back to go to sleep, they actually fall inwards and block airway?
Yeah. So that relates more to the side wall movements.
Okay.
So that's more that the tonsils then, you know, get dragged into the problem, but the underlying problem is not the size of the tonsils; it's the side wall of the throat, and it's typically
Muscular,
more so adults. Yeah,
structural.
yeah. So So more so adults. We will see it in children, especially low tone scenarios, cerebral palsy scenarios, and so forth. You know, and then, you know, that just adds layers of complexity to, you know, what makes all this very interesting. But in the mainstay, you know, small tonsils in a small airway. So you think of someone that's got major skeletal deficiencies, so their airway to start with is small. Those small tonsils can cause a problem. Whereas large tonsils in a perfectly good large airway, you might get away with. So it really is sort of just balancing out, you know, what is the airway and what is the effect, to determine, you know, where you're getting to with things.
Okay, that's a good point. And there's I think she's a pediatrician MD. I've heard her lecture. I think her name is Dr. Denise DeWald, I think. I have to look this up. But she talks about the sidewall movements and how it's an issue with like the palatal-glossus muscle. I don't know if you've ever heard, and she might have done some research. It's really interesting talking about like a muscular
Well,
issue. Hmm.
Well, the side, yeah. So the side walls, which is what we call the pharynx, is what's called the constrictors, and in particular one that's called the middle constrictor. And the reason that one's relevant is it attaches to a bone called the hyoid bone, which then attaches to the mandible, and has got the tongue sitting on top of it as well. And what happens in adults when we use mandibular advancement splints, that pulls the mandible forwards, which pulls the hyoid forwards, which puts sidewall tension around on those middle constrictors and reduces the lateral pharyngeal wall movement and collapse in those scenarios. So a lot of people think that, you know, the dental mouth guards for adult sleep apnea is about getting the tongue off the back of the throat. That's the minority of effect. The majority of effect is stabilizing the side walls of the throat. The palatoglossus is just one of the muscles. That's an internal muscle, but when we're talking about sidewall, we're really talking about the constrictors, and in particular the middle constrictor being relevant.
Yeah, I'll share her lecture that I saw a while ago. It was a really interesting analysis of how she mapped it all out. And I could be quoting some of that wrong, but it was like an interesting thing that it's not just the size of the tonsils, but actually a muscular component to it. So what are your thoughts on tonsillectomy versus tonsillotomy? Can you explain those and how you feel they might
Yep.
be warranted or not?
Yep. So again, I think history is a great teacher, you know, and I know that tonsillotomy has come onto the scene. The problem is it's not new. They were doing it 100 years ago and they abandoned it. So I think history teaches us something there as a starting point when, you know, people have done it before and they stopped doing it. That kind of gives us some insight as to, you know, what they were noticing over time. The problem is, you know, well, not so much the problem. The challenge is the pros and the cons. So the pros of a tonsillotomy is that it's less painful, which makes it a better recovery. There's a reduced chance of bleeding, which makes it a safer procedure. And that all sounds really good. The downside is that there's a risk of relapse. And the numbers sort of jump around a bit, and it's hard to know what numbers we can pin down to exactly. But I've seen anywhere between 3 to 20% relapse rates where they have to then go back and have surgery in the next year or two to complete the procedure. Now, one of the problems that we have with adenoid surgery is that we cannot completely get all the adenoids out. And one of the problems we can have is with the adenoids regrowing. So we have a problem with the adenoids where we wish we could get them all out, but we can't. So we have to accept there's a relapse rate, which is unfortunate but real. But at the same time, we have the opportunity to get the whole tonsil out, but we're choosing not to, and inviting the possibility of relapse when it could have been avoided in the first place. So my approach is that for the sake of the child going under an anesthetic, and for the sake of costs and the family having to take time off, I like to just do it once and it's done. So I do a full tonsillectomy and so forth. Yes, I know they're going to be sore. Yes, I know they're going to get better. Yes, I know there's a risk of bleeding. There's a risk of bleeding regardless. It'd be nice if that wasn't the case. We just got to be prepped and ready for that as an emergency scenario that can play out. And then at the end of the day, we're not going to have the scenario in front of us where we need to worry about having to do it again 2 or 3 years later. That's my approach.
Yeah, and that makes sense. You don't want to have to put your child under too many times if you can just fix it all at once. And adenoids might grow back. What % of the time do you think they tend to grow back, if there is even such a number?
Look, part of it. Yeah. No. Well, there is some guidance there. So part of it depends on how it's done. There are better ways than others of getting adenoids out. The historical traditional way is to do it blindly and just by feel. And the reason for that is that the adenoids sit at the back of the nose. When you do it, you're doing it through the mouth. You can't see it. There are ways of visualizing it now. So I do it with a dental mirror, but you can use a nasal telescope or the like as well. And it was an Australian study where the ENT surgeon, it was 429 consecutive adenoidectomies. And he did it the way we were all doing it, which was just to get a little thing called a curette, scrape the adenoids out, and then have a feel. And then when he was content that he'd done the adenoidectomy, he then put a nasal telescope in to objectively appraise that. And in 68% of the time, there was still adenoids there. 24% of the time, there was a lot of adenoids there. So that's an on-the-table failure rate that's really quite high using that technique. So from that point of view, it's not even about them regrowing. It's just about them just still actually being there in the first place.
Yeah.
When we look at visualization techniques and so forth, we're looking at a relapse rate that sits around the 1 to 3% mark is what the literature sort of indicates. So which is much better than a 24% failure on the table rate for that other traditional technique. So
it's a 1 to 3%.
So my number, well, look, my numbers are 0.1%. But that's just because I counted the first 2,000. And in that first 2,000, I had 14 that had to go back for regrowth.
Okay.
So that's how,
And this is interesting again. Okay. So 1 to 3% of the time, people have to go back to get the adenoids removed again.
1 to 3%, yeah.
Okay. That's interesting. Not trying to show off about all the problems my kids have, but my older son, I don't think they remove the adenoids fully, and he has allergies. And I remember seeing on a future. What? What's that?
You can't remove the adenoids fully. That's right. The problem.
Okay, they left okay, you can't. That's good. That's good. I should clarify that. Okay. Yeah, you can't remove them fully. You're right. I said that wrong. And maybe they left a more significant percent. I don't know. But he does have allergies. And I saw in a CBCT years later that it was like the adenoids were like this bump sticking out. Not like the normal sort of more rounded, but like almost like a corner. And believe
Yep.
it or not, I could see them when he opened his mouth and said "ah," and the soft palate elevated. You could see his adenoids in his throat. And that's kind of rare,
Yep.
right? But what helped?
Well,
And this,
that's not usual, but that's how they used to look for adenoids. Is they would put a mirror in and look inside the mouth and look up underneath. That's how they, before we had nasal telescopes, that's how they visualized the adenoids.
but even without a mirror, you could just see it with the naked eye.
Yeah, yeah, which is pretty impressive. Yeah.
Yeah, I was like, "Oh my gosh." So then I was like stressing out and I was like, "Do we need to do a surgery again?" And they put him on Singular for other sleep
Hmm.
disorder breathing reasons, and then the adenoids, and you also got another expansion of the palate, and then the
Hmm.
adenoids don't
Yep.
appear enlarged anymore. So perhaps the Singular
Perfect.
helped that? Is that something like
Possibly,
Singular?
yeah. Reducing that inflammatory drive to it all. Yeah, yeah.
Interesting,
The
yeah,
question
and
is
so
whether it then relapses again, because obviously there's a
right.
timeline that you're on medication for.
And the expansion maybe also because now we know research shows that the expansion can
Well,
reduce the size of adenoids and tonsils.
Well, the expansion improves the airway. What you've got to be careful with is that we know there's a natural resolution of tonsils and adenoids. So when we look at, for example, stick in your neck of the woods again, the chat study, which was a cohort of children that were assessed from an airway point of view, um, only focusing on sleep apnea rather than the whole sleep disordered breathing spectrum, but still much the same. There was a group of kids that 6 months down the track from their initial assessment were sleep study negative for sleep apnea. So we know that tonsils and adenoids can regress. The problem was in that cohort of children is symptomology wise, in terms of learning, behavior, emotions, they were still doing quite badly. So there was a time of brain growth, development, and formation that got into a certain pathway and pattern that
Mhm.
persisted even when the airway insult resolved. So that's one of the reasons why we advocate early interventions. And it's also important then to highlight that we can ascribe an outcome to a treatment. So we can do expansion and say, hey, look, the tonsils and adenoids got smaller. But it's just like, well, hang on. Half the time they're going to do that anyway, regardless. So how much of this is actually treatment effect versus other things? And the other thing that's important when we look at how some of those studies were done, in terms of what they were measuring lymphoid tissue volume. That's not the same as airway obstruction. What they need to do is measure the airway, because that's the important thing. And the reason I bring that up is that, first of all, adenoids is a bit easier, but trying to measure the volume of tonsils, for starters, it's really tricky off a CBCT because it's all soft tissue next to soft tissue. So you don't get the tissue delineation to do that. The other thing is, just think about I use this example of a water balloon. All right. And I'm going to give you two types of design of water balloon. One is a round one and the other one is a sausage shaped one. And we're going to fill both with the same volume of water. Okay. And we're going to hang them off of two hooks. Okay. So I've got my fingers in the screen. I've got it backwards on here. I'm feeling like I'm drunk. All right. So we've got two hooks. Okay. Now, the round ones are going to take up that space, whereas the sausage ones, I've got to go this way, sausage ones are going to go this way. There's more space between the sausage ones than the circle ones. Same volume, completely different effect if we translate that into an airway. So volume measurement of tonsils clinically is not even a thing. We don't measure that. We look at their size relative to the airway. So
Mhm.
what we need to measure effectively is the airway. So you've
And
got to
was
be
that
really
done?
careful about what's being measured.
Yeah, in
No,
the Audrey Yoon
no,
and
they,
Bakabaka
yeah,
study.
yeah, they
So
looked at, yeah, yeah,
volume,
not the crew. Audrey's fantastic
yeah,
and so forth, but we just got to be mindful of what's being measured.
volume.
And
Okay.
what was measured in that scenario was volume. We don't measure tonsil volume clinically.
Okay.
And doing it off a CBCT is a challenge. And what's more important is to measure the airway. Now, obviously, the airway gets better with expansion. We know that.
Yeah. And what's the best way to visualize the adenoids in a child? Would it be lateral ceph, CBCT, nasoendoscopy? What's the most accurate way?
Look, The gold standard is nasal endoscopy, but it's also the least accepted by a child. In which case CBCT by far trumps a lat clef. Lat clefs are, it depends on how well it was taken, what plane they were in, a little bit of guesswork. So the advantage of a CBCT is you can generate a lat clef, which is crystal clear, versus a true lat clef, which is just overlapping shadows.
So if you're doing a nasal endoscopy on a child, do you spray the numbing spray typically or no?
Yeah, I do.
Okay.
Yeah, no, I do. And it's optional. I like to, feel like we're making it more comfortable for them. And I think it does.
And if a
And
child
if they're
cried,
congested, it also decongests them.
oh yeah, that's true.
What's that, sorry?
And if you didn't spray like a numbing spray, say the child's crying when you're doing the nasal endoscopy, does that falsely make the adenoids look larger because they're like flexing?
No, it just compromises you. It just compromises the visualization process. And to be honest, if the child's crying, you're not even going to bother. You got to choose your battles in life.
Okay, it wasn't good we put my son in a headlock to do his nasal endoscopy. No, not joking, but they didn't give him a numbing spray. So, yeah, that was not fun. But one of my last questions, how about enlarged tonsils, adenoids, and recurrent ear infections? What's that relationship?
Yep.
I'm pretty sure I understand adenoids, but let's talk about that.
Yep. So let's change gears. Let's just talk about middle ear infections. So middle ear infections primarily are viral, sometimes bacterial. It's the most common childhood ear infection. Pretty much every child will have at least one episode growing up. Not necessarily 100%, but pretty much most of them. And most of them get better. Some of them need antibiotics, and the ones that are recurrent get drawn to the attention of the ENTs. And the reason for recurrences and so forth really comes down to a whole lot of dynamics. They are things that are intrinsic to the child. So, if they've got immune deficiencies that can manifest as middle ear infections, pretty rare. If they're living in a household where there's people that are smoking, definitely a contributing factor. If their nutrition is not fantastic, definitely a contributing factor. Another contributing factor is breastfeeding history, where if they're breastfed through to the age of 2, significantly reduces their chances of having middle ear problems versus not. And then again, lots of different reasons why that may or may not have played out, but that's a contributing factor. And then we have the way that they are developing skeletally. So having the mouth breathing, long drawn out face changes the way that these things called the eustachian tube, which is actually the critical part of this conversation, plays out. And then if they're also skeletally deficient, it's actually the movement of the soft palate that opens up the eustachian tube. The vector of force and pull in those that have the narrow high arch palates also affects the soft palate, also affects the eustachian tube. And then the elephant in the room, which I wanted to leave to last, is the adenoids. The adenoids sitting at the back of the nose are the seed point that then feed into middle ear problems. So adenoids actually sort of at the sort of junction of everything when it comes to ears, nose, and throat, because adenoids can cause ear problems, adenoids can cause nose problems, and adenoids can be associated with the throat problem of if the tonsils are playing up as well. So what we know is that kids that have tonsil and adenoid problems, we know there's an overrepresentation of orthodontic problems. We know that kids that have orthodontic problems, there's an overrepresentation of middle ear problems. And we basically got what we call a disease cluster effect, where, big tonsils, big adenoids, affects breathing, affects sleep, lowers their immunity because sleep disordered breathing affects immune function, opens the door for infections to be more obvious. The obstruction opens the door for more infections, and the skeletal deficiencies open the door. And then we've got the muscle tone and the myofunctional problems also then open the door. So we have this perfect storm of elements that in every kid, there's a balance of effect. And that's on the premise that they had eustachian tubes that otherwise would have been working properly. That's not always the case. You can have eustachian tube dysfunction developmentally, just independent of it all, that is then the fuel to the fire as well. So it's all these moving pieces that we sort of, notice, there's a sum effect clinically as to the problem.
Mm-hmm. Okay. And if a child has recurrent ear infections and enlarged adenoids, do you continue to just put PE tubes in, or do you say, look, we got to take the adenoids out as long as parents are in agreement?
Yeah. So if there's an airway problem, then the adenoids are coming out there and then, first time round. If it's just middle ear infection, nothing else is going on, there's no sign of any other issue, then we'll start with the tubes. And then we know that those tubes will come out. Again, I can go into the history of tubes if you want to go down that rabbit hole too, in terms of, their development and then they were abandoned and then they were revisited and so forth. So let me know if you want to go down that rabbit hole. But just to stay on task at the moment, when they come out, about 10% of children will need tubes again. And that's because their eustachian tubes, haven't quite got to where they need to be yet. So developmentally, about 10% of kids need tubes more than once. Now, in my hands, if that is coming down to a second round of tubes, I will do the adenoids at the time, because doing so in that group will reduce the chances of a third set of tubes by probably about 50%.
Okay.
The reason we don't do it first up is that it's only 10% of kids that are going to need a second set of tubes. So if we have 100 children, there's only 10 of those that are going to need their adenoids out for middle ear reasons down the track. So the other 90 would be over-treating. So that's why we don't do it first time round.
Okay, and what about if they're still getting ear infections with the tubes in and they have enlarged adenoids?
So that's a reason that you go and address the adenoids. So the tubes are still in, but the ear they're still playing out. So that sort of takes us a little bit back to old school ENT, and where they sort of go, all right, well, we've got to go back and these adenoids, we're going to have to clear them out because they're contributing, and so forth. And sometimes we even go to tonsils, which is really old school 1960s approach to middle ear disease. But look, it works. But we're talking about the few and far between. But yeah, absolutely. Ongoing middle ear problems despite tubes, you might go back and say, look, unfortunately, these adenoids are a problem. And we've got two choices here. We can ride this out, wait for these tubes to dislodge, and then we're going to go back and do adenoids and tubes again. Or in the meantime, let's just get the adenoids sorted and then let's just see where we get to once these tubes dislodge. There's options.
Okay. This is great information. We just hit the hour mark. I have a couple questions for you, but I don't want to take too much more of your time. So this is a bit off our topic of, we talked about asthma, tonsils, and adenoids, but I'm wondering for radiofrequency ablation for enlarged nasal terminates. So this is kind of like shifting gears here. Is that something children can benefit from, or do you wait until they're older? I just don't know what age. I hear different ages for
that. Yeah. So no, I use radiofrequency ablation in children a lot. It depends on their age, which sort of correlates to their size, and it also depends on their disease severity. So we're doing it for airway. The reason we're doing this is to shrink things down. So what I used to do is I if they were under 6, I would do radiofrequency ablation. And over 6, I would do the turbinate reduction with microdebrider, bone removal, soft tissue removal, As these allergies have escalated and got worse, I'm finding that I'm now doing the microdebrider assisted turbinate reductions in 3- and 4-year-olds and so forth, but because they're just that bad. But where they're not that bad, absolutely, I'll do the radiofrequency ablation. The upside to the ablation is the recovery is easier, and it's far easier technically from a surgical point of view because it's a smaller probe, easier to get into the nasal space. Everything that we talk about with turbinates has a relapse rate. So the relapse with radiofrequency, if it happens, and it doesn't happen often, it's usually about 2 years down the track. But that's 2 years of growth and development of the child. And then if they're in that relapse group, then they're going to be, big enough that we can do the microdebrider one. The microdebrider relapse rate, if it happens, which again is not that common, is usually about 5 years down the track. Okay. So it's really just a matter of knowing that most of the time when it works, it's done, but everything has a relapse rate. And in the scenario, the relapse rate is slightly higher and slightly earlier in the radio frequency versus the microdebrider.
And I assume the relapse
the reason you do one or the other at the time.
Okay, and I assume the relapse because you haven't addressed the underlying cause, which could potentially be like you want to address.
This is why you always got to check for allergies and stuff. And like we talked about in the previous episode, sometimes those allergies don't declare themselves at the time.
Okay,
like they're there, but we can't see it.
Could you call it like a sensitivity if somebody didn't show allergies and they're like non-allergic rhinitis? You can say, yeah, but you might be sensitive to certain things or something. I don't know. Okay,
you can use whatever word you like. Yeah.
Okay. So because I do have like a patient who no allergies showed up, but there's allergy symptoms. So it doesn't mean they don't have allergies. And so could you still treat, like you could still treat with some allergies?
It means that they clinically yes, but diagnostically no.
Yeah.
So it's where the test results aren't giving us the answer that we're looking for.
And you could always
we kind of know, but we can't prove it.
And you can kind of do a trial with allergy medication to see if they're better. That could be a sort of diagnostic.
Okay. Yeah, you do a trial of medication. Yeah, absolutely.
Last thing is septoplasty on a child. What's the youngest age you would do septoplasty?
Well, the youngest one I've done is 4. The literature, I've got literature that shows them being done in babies, and so forth. When they do cleft palate repairs, if the septum is out of alignment, there's some clinics where they'll address that at the time. It's really is, again, just a historical journey of things where the original research was done in pigs, where they did basically removal of the whole septum, and then saw that the nose didn't grow properly and said, oh, you can't operate on the septum. So hang on a sec. This doesn't relate to what we're actually doing surgically. But, it was enough to, send a little bit of concern through, the ranks, and the paradigm became, well, you don't do nasal surgery, on the septum in a growing child, because you might alter the way that their facial, development plays out. But the problem is, as you and I know, if the child can't breathe properly, it affects the way their facial growth and development plays out.
Yeah.
And they're not breathing properly, and they're not sleeping properly. So we've got all the neurological stuff, and we've got the cardiovascular stuff, and they've got the general body system stuff because they can't breathe properly.
Yeah.
So in the pecking order of concern, not to be cavalier about it, but we really got to put into the context is, are we really worried about a nose that might grow, slightly smaller, but for the benefit of being able to breathe and sleep properly and have better overall facial growth and development as a result as well, being, a nice little side effect. And that's where, the pushback is coming from now to that paradigm.
Again, it's all about,
but again, when I was, it's got to be about big picture, and it's got to be about history. History can teach you so much. You've just got to go back and just read and learn.
And in our field, looking for the ENTs that do understand the big picture of airway and sleep, because if they don't, they might make different decisions, clinical decisions for the patients versus those who are educated in the consequences of sleep breathing disorders. So today we covered so much. We talked about asthma, and I'm going to do a little summary, make sure I learned more than I thought. I always learn way more than I thought because I have pages of notes here, but I'm going to summarize as best I can. We talked about asthma, and the breathing channels can constrict, but that's reversible with medication. Things that might trigger asthma: allergies, exercise, temperature. Temperature can trigger that. And there's also a mucus plugging effect in someone who has asthma. And half the people with allergies have asthma. That's really interesting. I didn't know that number beforehand. And treating allergies can control the asthma better. Really important. There's different kinds of reflux. There's lower gastroesophageal reflux, GERD. And then there's also that upper reflux, which we might call silent reflux or laryngopharyngeal reflux. And that can cause asthma-like symptoms and nasal congestion. And there's different reasons for that. You can test differentiating asthma versus reflux by seeing the responsiveness to medication, right? Medications. And we talked about vocal fold nodules. Sinus disease can be linked to adult onset asthma, which is interesting. And people can definitely have exercise-induced asthma. That's not like a phony thing. That's a real thing. Maybe it's overdiagnosed. I don't know. Asthma links to sleep disordered breathing because of the different components like nasal allergies. But more importantly, sleep disordered breathing is a disorder of systemic inflammation, right? People with sleep disordered breathing have systemic inflammation, and that can lead to asthma and allergies and issues like that. So when we treat the sleep disordered breathing, the asthma severity decreases. Again, it's all linked, right? And there's also asthma versus asthma-like symptoms, which could be like panic attack type things that isn't asthma, but could have similar feelings. And breathing retraining can help with anxiety. And that's interesting about the PE yoga program. If that does come here, that would be amazing to have yoga programs in our schools to help children with slower, calmer breathing. Mouth breathing can irritate the lungs, but might not be a factor in causing tonsils to enlarge. There's other factors that can cause tonsils to enlarge, one of which being viruses. That's probably the most common. Bacteria, reflux, smoke, and allergies, but maybe it's just mold, not general allergies, but mold could be a contributing factor to enlargement of tonsils and adenoids. But we have a lot of mouth breathers that don't have enlarged tonsils. Important point to remember. But enlarged tonsils can cause mouth breathing and can cause a low forward tongue posture that can lead to open mouth breathing as well. We want to not fear mold because there's so much mold around us. So don't fear mold. If you have allergies to mold, then fear it. No, I don't know. Then that's more of a thing. But tips for mold: clean your air conditioning units. If you use a CPAP, clean the filter. Don't forget about the filter, that little button on the side that you pull open, and there's a little sponge that could be moldy. Potted plants in the house can contribute to mold. Dry your clothes inside. HEPA type filters, which are the expensive, the good ones. Tonsils and adenoids we talked about, they're not the same tissue. And when we see unilateral disease in our patients, in the ENT realm, that's a red flag. So one tonsil being significantly larger than the other, or blockage significantly on one side. Different size of adenoids. So this is really interesting that I learned is a grade 2 tonsils is a 50-50 chance of contributing to airway obstruction. Grade 3 tonsils has 80 to 90% chance of contributing to airway obstruction. And grade 4, of course, 90 and 97%, really large percent. But I always kind of thought grade 2 are probably fine, not a big deal. But now I'm thinking, wow, 50-50, like 1 in 2 kids or even adults, that could be a huge factor to their airway issues. So we got to refer to airway focused ENTs for any of these grade 2 tonsils or larger. And even mandibular advancement devices, we talked about the pathway of how that can lead to not just forward tongue pulling the tongue forward and the hyoid forward, but the pharyngeal constrictor muscle tightening, which helps hold the airway open. Adenoid relapse rate, 60% of adenoids are not removed fully, or there's still a good amount of adenoid tissue left, but 20% of adenoidectomy is there's a lot of tissue left. So we know you can't fully remove all the adenoid tissue, and the relapse rate of patients needing an adenoid removal surgery again is about 1 to 3%, but not for you. Yours is point something.
Yep.
Because you know how to remove.
Oh yeah, no, I did my math wrong. No, I'm the same. I'm 1.4%.
1.4. Okay. 1.4. So, I mean, that's a pretty low rate, but it happens. And if it's going to happen, it's going to happen to my kids because I get to deal with all that. But anyways, we talked about ear infections, that relationship between enlarged tonsils, adenoids, ear infection, and there's this disease cluster effect. We all know it. Orthodontic issues, skeletal issues, ENT, allergy, it's all clustered together. You call it the perfect storm. That's why our team approach to assessment and treatment is crucial. And I think it leads me to always want to say it's very overwhelming for our patients, whether they're children or talking to the parents of children or adults with airway issues, helping them understand that these issues are multifactorial and helping to kind of be a guide for them. At least I feel like I do that with my patients a lot. I kind of give them a heads up. I'm about to overwhelm you because there's going to be a bunch of referrals and information, and we need to sort of sequence the treatment plan. But these issues are multifactorial, especially in an older child or adult. Compensations have developed, structures have changed, and it's all related with ortho, ENT, allergy, myofunctional. And we talked about PE tubes for ear infections. 10% need them again. We talked about, in the end, radiofrequency ablation techniques. Kids younger than 6, you could do that. I didn't realize little ones can get that. Greater than 6, you might do like more turbinate reduction, which has a lower relapse rate maybe than radiofrequency ablation. So there is so much an ENT who is airway focused can do for our patients. There is so much. So I think it should be on the rarer side that we are not referring to an ENT as part of our patient care. We got to rule out any of these medical pathology as to why our patient is breathing through the mouth, resting with their tongue low and forward, feeling congested, whatever these issues are, because it is highly related and highly likely that the ENT could probably help or at least rule out a medical pathology, right? Do you feel like that's a good,
absolutely.
And
absolutely.
It's really important to keep that team effort, those multiple eyes on our patients to help resolve these issues fully. Because I think if we don't, you won't get full treatment or resolution, or there'll be relapse. So do you have any closing words? I know I've used your time a lot, so I thank you so much. Anything you want to say, to help with patients getting
I think it's always good for the parents to have a very simple take home. And my simple take home is you do not know what your child is doing at night until you take the effort to go and watch over them. And the things that you need to be watching out for is snoring, mouth breathing, stopping breathing at night, waking up tired and grumpy in the mornings. They're all clues we've got a problem. There's lots of other clues that we can go hunting and searching for, but they're the big ones that parents can very easily look for and find. And in those situations, don't take no for an answer. Okay, if your child has got problems, they're struggling and they're sort of starting to tick some boxes of things, don't take no for an answer. Just keep being their advocate and just find the right people that will do the right things to get them better for you.
Exactly. Perfect. And you've said in the past, all noisy breathing is a problem, but not all breathing problems are noisy. Is that the quote?
Yeah.
So
it's really it's very similar to it. Yeah. Okay. All noisy breathing is obstructed, but not all obstructed breathing is noisy.
Yes.
It really just comes down to how much you're being choked. If you're being choked a little bit, you'll make noise. You're being choked a lot, you can't make any noise at all.
Yeah.
So the noise is not an indication of severity.
So we got to look at facial features. We have to look at symptoms. And for children, behaviors is huge component to underlying sleep and airway problems, behaviors. And parents can see that during the day. Teachers can see that. So thank you so much for all of your time. You're a blessing. Everybody has probably learned so much. And I thank you again. And I think everybody should also purchase your books or, Amazon them, audiobook, and really get more information there as well. Thank you.
Absolutely.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next